Hello everybody, in this video I'm going to talk about compensatory physiological responses in heart failure. The failing heart evokes three major compensatory mechanisms to enhance cardiac output. Although initially beneficial, these alterations ultimately result in further deterioration of cardiac function. If we take a look here on this figure, which represents the main cardiovascular consequence of heart failure, which is the edema, we can observe that this edema is a result of increased capillary filtration due to the increased venous pressure, and on the other hand, it's also a result of the increased sodium and water retention as a result of the increased secretion of aldosterone, renin, and angiotensin 2 because of the decreased renal blood flow, which is a result of the increased blood pressure and the stimulation of sympathetic activity. Of course, this blood pressure is decreased as a result of the decreased cardiac output. So it's like a flow that begins with the cardiac failure and finishes at edema. As we see here, the major compensatory physiological responses in heart failure are, first of all, increased sympathetic activity. As we see here, baroreceptor response will occur as a result of the progression of heart failure, and here the brain will stimulate the SNS, or the sympathetic nervous system, and we will have increased heart rate and increased contractility. The second compensatory physiological response is the activation of the renin-angiotensin system. So the RAAS, or renin-angiotensin aldosterone system, will be activated, and the GFR, or glomerular filtration rate, will decrease in kidneys. So we will have fluid retention, and as a result of fluid retention, we will have increased preload. The third response is the myocardial hypertrophy, which is one of the results of the increased ventricular wall tension. So here we will have myocyte growth and we will have this hypertrophy. The increased heart rate and contractility with the increased preload and hypertrophy, all of these things will participate in the increasing of cardiac output. Now I'm going to talk about the increased sympathetic activity. Here we should know that baroreceptors sense a decrease in blood pressure and activate the sympathetic nervous system, which stimulates beta-2 adrenergic receptors in the heart. This results in an increased heart rate and a greater force of contraction of the heart muscle. In addition, vasoconstriction enhances venous return and increases cardiac preload. These compensatory responses increase the work of the heart and therefore can contribute to further decline in cardiac function. Now, about the activation of the renin-angiotensin system, a fall in cardiac output decreases the blood flow to the kidney, prompting the release of renin, with a resulting increase in the formation of angiotensin 2 and release of aldosterone. This results in increased peripheral resistance and retention of sodium and water. Blood volume increases and more blood is returned to the heart. If the heart is unable to pump this extra volume, venous pressure increases and peripheral edema and pulmonary edema occur. These compensatory responses increase the work of the heart and therefore can contribute to further decline in cardiac function. Okay, actually when we take a look on this figure, we can understand more about the steps of the activation of the renin-angiotensin system, and thus understand why we will have water and salt retention and high blood pressure as a result of this activation. First of all, we should observe that we have apparatus within kidneys which is called juxtaglomerular apparatus. This juxtaglomerular apparatus is stimulated when the renal blood perfusion into the kidneys will decrease due to the heart failure progression. When the heart is going to insufficiently pump less volume of blood into the kidneys to perfuse these kidneys. So here we will have decreased volume of this blood, and this will actually send a stimulatory signal into this apparatus and activate this apparatus, which itself is going to stimulate the kidneys to secrete renin. Renin itself is going also to send another stimulatory signal, which is going to be into the angiotensinogen, which is secreted by the liver, and this renin will convert and transfer or participate in the transformation of angiotensinogen into the angiotensin 1, which is the inactive form of angiotensin. This angiotensin 1 is going to be angiotensin 2 is going to be converted into the active form, which is the angiotensin 2 by the function of ACE or angiotensin converting enzyme, which is secreted by cells within the endothelium of kidneys and lungs, within the pulmonary and renal endothelium. Now, angiotensin 2 actually it does many things. First of all, it can send stimulatory signal into the central or the sympathetic nervous system, and thus we will have stimulation in the sympathetic activity within the nervous system. Second, very important and substantial thing is its role in the water retention and the reabsorption of H2O or of water molecules, by the way. And this can be done by one direct and two indirect ways. The direct way here is it's acting directly to the tubule, and here we will have the sodium cations or positively charged ions, and the chloride anions. These sodium and the chloride will reabsorbed into the body directly as a result of the function or the act of angiotensin 2 to the tubule within the kidneys. The second thing, the potassium is going to exit the body, and we have potassium cation excretion. The third thing, water molecules will directly reabsorb into the body when this angiotensin 2 acts. Okay, this is the direct way of angiotensin 2 to participate in this ion exchange. The indirect two other ways, the first one is by acting on the adrenal gland, and specifically the cortex of adrenal gland. We know that adrenal glands are on the top of each kidney in our bodies. So the adrenal gland will recept stimulatory signal from angiotensin from the angiotensin 2, and as a result it will secrete aldosterone, which also itself participate in the water retention, and potassium excretion, and sodium and chlor or salt reabsorption. This is the first indirect way by acting on a gland which is adrenal gland and secrete the aldosterone. There is another gland which is the pituitary gland, and especially the posterior lobe of this pituitary gland. Angiotensin 2 also acts on this lobe of this gland, and thus this gland will secrete ADH or antidiuretic hormone or vasopressin, and it also will act on the collecting duct and will increase the H2O reabsorption. The last thing that angiotensin 2 actually does is acting on blood vessels. Here in the blood vessels, within the blood vessels, we have arterioles. When we talk about arteriole, we have receptors to this angiotensin 2 on the surfaces of these blood vessels. So when this substance bind to its receptor on these blood vessels, we will have a constriction, and this arteriolar vasoconstriction will increase the blood pressure, because here we will have narrower tube that the blood will flow within, so of course its pressure will increase. So these 5 things will lead to water and salt retention and effective circulating volume will increase, of course, as a result. This is the second thing. The third thing, as a result of the increased circulating volume of blood, the perfusion of the juxtaglomerular apparatus will increase, and of course, when this perfusion increase, it will send inhibitory signal to the kidneys and stop this system. Now, the third compensatory physiological response is the myocardial hypertrophy. The heart increases in size, and the chambers dilate and become more globular. Initially, stretching of the heart muscle leads to a stronger contraction of the heart. However, excessive elongation of the fibers results in weaker contractions, and the geometry diminishes the ability to eject blood. This type of failure is termed systolic heart failure and is the result of a ventricle being unable to pump effectively. Less commonly, patients with heart failure may have diastolic dysfunction, a term applied when the ability of the ventricle to relax and accept blood is impaired by structural changes such as hypertrophy. The thickening of the ventricular wall and subsequent decrease in ventricular volume decrease the ability of heart muscle to relax. In this case, the ventricle doesn't fill adequately, and the inadequacy of cardiac output is termed diastolic heart failure, a particularly common feature of heart failure in elderly women. Diastolic dysfunction in its pure form is characterized by signs and symptoms of heart failure in the presence of a normal function of the left ventricle. However, both systolic and diastolic dysfunction commonly coexist in heart failure. Here we can see what do we mean by myocardial hypertrophy when we see this hypertrophic heart and compare this figure to the left one, which is the normal heart. If the mechanisms listed before adequately restore cardiac output, the heart failure is said to be compensated. However, these compensations increase the work of the heart and contribute to further decline in cardiac performance. If the adaptive mechanisms fail to maintain cardiac output, the heart failure is termed decompensated. Now I'll move to talk about the therapeutic strategies in heart failure in brief. Chronic heart failure is typically managed by reduction in physical activity, low dietary intake of sodium, this means less than 1,500 milligrams per day, treatment of comorbid conditions, and judicious use of diuretics, inhibitors of the renin-angiotensin system, and inotropic agents. Drugs that may precipitate or exacerbate heart failure, such as nonsteroidal anti-inflammatory drugs or NSAIDs, alcohol, calcium channel blockers, and some antiarrhythmic drugs should be avoided if possible. Patients with heart failure complain of dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, fatigue, and dependent edema.